Assalamu alaikum and welcome to the course, and I must congratulate Dr. Shah for his effort in organizing this course. I think it's a valuable thing for our trainees who are appearing in the examination. So Dr. Shah really deserves a big hand of applause for this. My apologies for not being here physically. I've been given this task of talking about prostate cancer and provide you with an update. It's a huge topic. There are a lot of things to talk about. So I've tried to look at some of the significant areas, and so I'm going to, and I've providing a brief overview of what I'm going to talk about in the next 20 minutes that have been allocated to me. So essentially, we're going to touch upon what is screening and early detection, what's the current thinking on these two areas. About localized prostate cancer, we're going to talk about how to do risk stratification and use that risk stratification to be able to make a decision about treatment. What is active surveillance and interventional treatment decision making? Once you have done the definitive treatment in terms of either radiation therapy or radical prostatectomy, and you have a biochemical recurrence, how do you define biochemical recurrence? How do you treat biochemical recurrence? And how do you risk stratify biochemical recurrence? So we're going to talk about that. The next line in the spectrum is a hormone-naive metastatic or locally advanced prostate cancer. And we're going to touch upon briefly about how to manage that. And then obviously we're going to talk about a little bit in the end about the castrate-resistant prostate cancer. Well, screening is essentially a population or a mass or group-based thing which is used by health authorities in order to achieve two objectives. Number one, to reduce mortality related to prostate cancer. So by early detection, we like to identify prostate cancer in the stages where it is amenable to treatment. And also to be able to maintain the quality of life by those interventions. In comparison, early detection is an individualized risk-adapted strategy for identify cancer in the earlier stages. Now, it is different from screening because screening is mass and population-based, and this is stratified to a risk group. So you only do it on patients or people who are more likely to have a prostate cancer. So typically 50 years above and 45 years above for those who have a strong family history. More recently, there have been significant advances in understanding the molecular biology of prostate cancer. So gene mutation and germline testing is becoming the in thing now, and we know that patients who've got BRCA2 gene mutation are at increased risk. And those who have both BRCA1 and BRCA2 mutation, they can develop prostate cancer in a much earlier age. Well, as for the screening, we know that PLCO and ERSPC are the two major trials which took place about 15 years back. We had initial results, and subsequently we had updated results from the ERSPC data. And I'm going to show you the 4 papers that have come out from the ERSPC trial. They indicated that the first one, which has a follow-up of 9 years, you need to screen 1,400 patients or people or men to detect one prostate cancer. And you need to treat them 48 patients by definitive treatment or either surgery or radiation therapy to save one prostate cancer related death. Then we had 11 years, 13 years, and now we have 16-year follow-up data available from that trial. And currently, you need to detect 570 men to detect one prostate cancer. You need to treat 18 in order to save one life from prostate cancer-related death. We've talked about germline mutation. If you look at the guidelines, the recent guidelines, the evidence is strength of rating is weak because there's no randomized trial, obviously, in order to show that germline testing can actually be of help. Just an introduction, what germline testing is, that germline testing is done on tissues which do not harbor cancer. So for example, if we talk about prostate cancer, we would not do germline testing on prostate cancer tissue, but we will do it on some other tissue. For example, you take blood. Now that blood is collected, it undergoes fractionation. After fractionation, you do DNA extraction. And then you prepare the DNA library, and that library is then sequencing is done, which is called the NGS, or the new next generation sequencing. And then software basically analyzes that data and matches with known mutations. For example, BRCA1, BRCA2 mutation. It identified whether this person has a BRCA1, BRCA2 mutation. And in that case, he is more likely to develop cancer at an early stage, and that cancer can progress. So current guidelines on screening is, I will just only talk about the strong evidence which is available that do not subject men to PSA-based testing without counseling them potential risk and benefit. It's important that the screening should start at 50 years of age and 45 for those who have a strong family history, or men of African descent, or men who carry BRCA2 mutation. The screening can start even at 40 years of age. One should stop screening if the life expectancy is less than 15 years. So if you determine a life expectancy of somebody, say at 75 years of age, then you would not do screening after 62 or 63 years of age. So that's an important. So this is strong evidence in support of screening. Now, why this has happened, and this is after the US task force recommendation, and because the screening tool that we use is PSA. And PSA, we know, is not a very reliable tool for diagnosis. It's a very reliable tool for prognosis and follow-up of patients, but not for diagnosis, because there is no PSA on which you cannot have a prostate cancer. So even at a PSA of under 0.5, you can have a prostate cancer in up to 7% patients, and 1% can even have a significant prostate cancer with the ISUP grade of greater than 2. Similarly, the normal range that we define up to 4, up to the range of 4, you can have 27% patients who can have prostate cancer, and about 7% who can have cancer which is significant, which is ISUP grade 2+. So various modifications of PSA has been defined, which includes PSA density. We know that 0.2 is a cutoff used. PSA velocity, which is rate of change of PSA over time. So if the PSA is rapidly increasing versus it is slowly increasing, indicates the aggressiveness of disease. The PSA doubling time is something which is used. So if you have a PSA of 0.3 and it becomes 0.6, it means that the PSA has doubled from nadir value. And if it is taken 6 months, it's one entity. If it is taken less than 6 months, that's a different entity. So how long it has taken for the PSA to double is the PSA doubling time. And PSA free upon total ratio. And all these things were very important until a few years back. But and they're important from the diagnostic perspective, that the PSA that you are looking at, is it significant and is there a possibility of cancer or not? So all these factors can be used. However, now with the advancement in the technology related to the MRI scan, has really changed the scenario, and these things are not as important as they were about 10 years back. So the sensitivity of multiparametric MRI scan is for ISUP grade 2 plus tumors. So ISUP grade 2 means more than 7 Gleason score, and which is at least 1 centimeter, so 10 millimeter tumor. The multiparametric MRI means that you need to do T1, T2 weighted images, as well as DWI and ADC calculation, MR spectroscopy, and DCE, which is dynamic contrast scans, examination. So these are the 5 modalities used, but the most important is the T2 weighted image and the DWI and ADC calculation. And these are various the various imaging findings which can be used to grade lesions from 1 to 5. The higher the grade, which is called the PIRAD, the higher are the chances of significant malignancy. So if you look at these PIRAD grading, PIRAD 1 to 2 is very low and very less chances of significant cancer. PIRAD 4 and 5 means a very high chance of significant cancer, and PIRAD 3 is in between. So these are the various lesions, and you can see that there is a hypo-intense lesion in the peripheral zone. This is the peripheral zone. This is the central zone, transition zone. And these are hypo-intense lesion in the peripheral zone here, which are not very suspicious. As you move down, you see that these lesions become really very hypo-intense, and they are highly suspicious of malignancy. Similarly, here in the T2 weighted images, and if you look at this picture in the bottom, this is a big hypo-intense lesion with capsular penetration, and there is a very significant chance of a malignant cancer in the prostate with this PIRAD 5 scan. So if you look at the use of MRI scan in the latest EAU guidelines, it should not be used as an initial screening tool. So you do PSA, and if there is a suspicion about situation, then you would probably use MRI scan either to indicate biopsy, or if there is a high suspicion you want to stage disease, MRI scan should be done. You need to adhere to the PIRAD guidelines for MRI in order to discuss the patient in multidisciplinary settings. Perform MRI before prostate biopsy so that the biopsy related artifacts are not there. And when MRI is positive, that is, it is greater than 3, combined and targeted systemic biopsies be done. Now for prostate biopsy, because of the infective complications related with transrectal biopsies, it is now recommended that transperineal biopsies be done. It's a little more of a more difficult procedure. It requires anesthesia, but the chances of infectious complications are reduced significantly if you do transperineal biopsies rather than transrectal biopsies. If you're doing transrectal biopsies, it's important that you do povidone preparation of the rectum in order to decrease the chances of infective complication. Antibiotic prophylaxis should always be done in patients who are having transrectal biopsies. So once you diagnose an organ-confined cancer, what is the treatment protocol? Well, you have to risk stratify these patients, and I'll just talk about risk stratification. Then once you have risk stratified them, you look at the life expectancy of this patient and then make a decision whether you want to do an active surveillance / watchful waiting, you want to do active treatment, which is radiation therapy and radical surgery. There is a bit of a role for some other modalities of treatment, but they are more of experimental. So when you have to make a decision between active surveillance and watchful mating, you need to understand the difference between the two. So the difference in 5 criteria. Number 1, what is the intent? If your intent is to treat the patient, then it is the patient has to go for active surveillance. If it is to palliate or to observe and reduce the chances of complication related to treatment, then the patient goes for watchful waiting. The follow-up schedule is very strict and defined in case of active surveillance. The assessment and the markers used are also defined. The patient's life expectancy is important. The aim of the treatment is also important. So the aim of the treatment in active surveillance, curative, whereas in watchful waiting, it's palliative. Follow-up is predefined, and in watchful waiting, the follow-up is more patient-specific. You do DRE, PSA, multiparametric MRI scan, and biopsy at least once a year in patients who are active surveillance, whereas there is no defined protocol for watchful waiting, and it is at the discretion of the surgeon, and it is based on the patients. Whom are selected for watchful waiting versus active surveillance? Well, if you have a life expectancy of greater than 10 years, the patient becomes eligible for active surveillance. Whereas if the life expectancy is less than 10 years, then watchful waiting. The whole idea of active surveillance is to minimize treatment-related toxicity without compromising survival. Whereas in watchful waiting, minimize treatment-related toxicity is the main aim. So how do you assess patients' life expectancy? Well, you have various scoring systems, and the one that are commonly used or advocated include the geriatric 8 and the Mini-Cog and clinical frailty scale for health status screening. So once you have performed that, and if the patient score on, say, G8 is greater than 14, then they would have to go for a more specialist geriatric evaluation in order to determine what are the chances of this person surviving more than 10 years. So the general guidelines for the management of organ-confined cancer is that we need to inform patients that there is no superiority of one definitive treatment over the other. And there is no difference between active surveillance or deferred management versus active treatment. So this is something that you need to explain to the patient right in the beginning. So watchful waiting is a policy for asymptomatic patient with less than 10 years of life expectancy, and inform patients that all treatments, be it radiation, be it surgery, or be it focal treatment, have side effects. Well, as for the surgical treatment, it's important to remember that the lymph node dissection, when it is deemed necessary, should be performed as a lymph node, as an extended lymphadenectomy. Do not perform nerve-sparing surgery if there is a risk of ipsilateral extracapsular extension, and these are other criteria to determine when are the chances of extracapsular extension is significant. It's based upon the T stage of the disease, the pathological evaluation, nomogram, and multiparametric resonance imaging findings. Neoadjuvant androgen deprivation therapy has no role in prior to a surgical treatment. It has a role prior to radiation therapy. Well, the radiation therapy, there are certain terminologies used which the trainees need to understand. We use the term IMRT, which is basically the intensity modulated radiation therapy, and it is basically adapted to the prostate size and shape and location of the cancer. So, and this is treatment basically involves, first of all, planning CT scans to understand the anatomical configuration, and then the radiation field is set accordingly. Now, not only that prostate cancer, this is basically done to decrease the chances of radiation-related toxicity to the surrounding organs, including bladder and rectum. Now, between treatment modalities and between sessions, the prostate also changes in terms of the tumor position. Breathing also can change the position and localization of the cancer. So you have to do it with IGRT. And IGRT basically is a technique by which you can account for these changes between positioning and between separate treatments. The other term that is used is fractions. So the conventional fractionation administered 5 times a week for 8 weeks. If you do moderate hypofractionated treatment, then you do at a higher dose over less time. So typically, the treatment of choice for prostate cancer is IMRT with IGRT using moderate hypofractionation. Okay. So you need, even as surgeons and surgical trainees, you need to understand these terminologies. So if you look at the guidelines, I think it is quite clear that we need to offer intensity modulated radiation therapy, IMRT, plus image-guided radiation therapy, IGRT, for definitive treatment of prostate cancer by EBRT, which is external beam radiation therapy. You need to offer moderate hypofractionation, as I've explained, with IMRT and IGRT to prostate cancer with localized disease. And then there are details about what to do for how much radiation be given, 60 gyre per 12 fractions in 4 weeks, or 70 gyre per 28 fractions in 6 weeks. And this is really the moderate hypofractionation regimes currently in use. Treatments other than radiation and surgery are the cryotherapy and HIFU. These are all for clinical trial settings and cannot be offered as definitive treatment, although you need to inform patients that these patients are also at increased risk of complications compared to watchful waiting. This is the EAU risk stratification, and it is based upon 3 things, which is clinical stage, PSA, and the Gleason sum, or ISUP grading. So if the PSA is less than 10, ISUP is grade 1, which is 3+3 Gleason, which means really under 7 Gleason sum. Clinical stage is T1 to T2A maximum, then it is a low risk cancer. If the PSA is between 10 to 20, or the Gleason grade is 7, and this clinical stage is T2B, then it is intermediate, whereas PSA above 10, Gleason greater than 7, with ISUP grade 4-5, and clinical T2C cancer is again high risk cancer, and then there is very high risk for locally advanced cancer, which is any PSA, GS, any Gleason sum with clinical stage T3 to T4 with or without lymph nodes. So follow-up after curative active treatment with curative intent after radical prostatectomy, PSA should be undetectable, which means that it should be less than 0.1 nanogram per ml. So any PSA rise after radical prostatectomy is a relapse. So anything which is more than or greater than 0.1 nanograms per ml after radical prostatectomy is considered as residual prostate cancer tissue, and it should be treated as such. After an undetectable PSA is obtained following radical prostatectomy, PSA of greater than 0.4 and rising predicts further metastases. Following radiation therapy, an increase in PSA greater than nadir plus 2 nanograms per ml is best predicts further metastases. So it's important that PSA monitoring should continue for these patients for a long period of time. So if you have a PSA which is more than 0.1 nanogram per ml after radiation therapy, or greater than 2 nanograms per ml after EBRT, this is called biochemical recurrence. Now, biochemical recurrence can be EAU low-grade recurrence or low-risk recurrence, or it can be a high-risk recurrence. So following radical prostatectomy, if the PSA doubling time, meaning that PSA moving from 0.3 or 0.2 to 0.4 in less than 1 year is considered, and greater than 1 year is considered as a low risk. And if the pathological grade of the patient is less than 4, then it's low risk. After radiation therapy, if the interval of biochemical failure is greater than 18 months, it's a low risk. If the biopsy ISUP grade is greater than 4, then it's less than 4, it's a low risk. So basically, the PSA doubling time and the pathological grade are used to define the good versus bad biochemical recurrence. So most of the low risk or good biochemical recurrence can be observed carefully, whereas most of the high risk recurrence would require some form of a salvage treatment. So what are the second line treatment for biochemical recurrence? Well, the quality of evidence is strong for offering salvage radical prostatectomy after brachytherapy or HIFU or cryoablation with biopsy proven local recurrence, but only in a trial setting. Biochemical recurrence after radical prostatectomy offer monitoring, including for low risk biochemical recurrence, or offer early stage IMRT plus IGRT to men with 2 consecutive PSA rises. PET scan has a significant role in assessing the imaging of the abdomen is also important. And systemic treatment with androgen deprivation therapy to M0 patient is not recommended with a PSA doubling time of greater than 12 months. CRPC, which is castrate-resistant prostate cancer, is defined as, number one, we need to have a castrate level testosterone levels. It's important that if you've done surgical orchiectomy, you need to have a testosterone level. Or if you're doing medical castration, you need to check the testosterone to make sure that these are castrate level before you term them as castrate-resistant prostate cancer. Biochemical progression is assessed by 3 consecutive rise in PSA at least 1 week apart, resulting in greater than 250% increase over the nadir value. So if the nadir value was 0.1 and there is a 50% increase, meaning 0.15, so this is considered as a biochemical recurrence. Radiologically, you can define castrate-resistant if there is an appearance of new lesion with continuing hormone ablation. CRPC is essentially treated by second-line hormonal therapy, which includes abiraterone and enzalutamide. It can also be treated by chemotherapy. The first line is cabazitaxel and docetaxel. Immunotherapy and radiopharmaceutical like radium are also frequently used because majority and the bulk of the disease is really in the bones for such patients. For bone metastases, it's important that your patient should be on board protection, which means that should be on some form of either bisphosphonate or denosumab. They should receive vitamin D and calcium supplementation. And whenever you're monitoring with PSA, you should also monitor the calcium and the vitamin D levels in order to make sure that their bones are protected, because they're at increased risk of skeletal related events. In patients with spinal cord compression, either start with high dose corticosteroids or assess for spinal surgery following radiation, or for radiation alone if surgery is not appropriate. So I'll stop here. Thank you very much for your attention, and I wish you all very well in your examination. Thank you.